Okay, I think we should get started. It's my great pleasure to introduce our speaker today, Dr. Aman Mahajan, who will be delivering the Herman B. Stein Endowed Lecture. Dr. Stein was a 1923 graduate of the CU Medical School, and after his residency training at the Colorado General Hospital in Denver, he practiced as an anesthesiologist until 1965. Dr. Herman B. Stein of Denver and his wife then endowed the department with the first lectureship of anesthesiology in 1969. His son Donald then also became an anesthesiologist and then assumed stewardship in 1976 after his father's death, and also practiced at least for 40 years as an anesthesiologist. Then his daughter Susan then finally completed a very rare trifecta of a 3-generation anesthesiologist family, and she also took a very active interest in the lectureship and the department. And Dr. Mahajan, with his dedication to anesthesiology, clearly follows the footsteps of the Stein family. Dr. Mahajan is the Peter and Eva Safar Professor and the Anesthesia Department Chair at the University of Pittsburgh. Dr. Mahajan earned his MD from the University of Delhi in India in 1991. Between 1994 and 1998, he did his residency training and a fellowship in cardiac anesthesiology at the University of California, Los Angeles. In 2006, he earned his PhD in cardiac electrophysiology and biophysics, also at UCLA. Dr. Mahajan then stayed at UCLA for several years, became faculty, became the program director of cardiothoracic anesthesiology, became the division chief of cardiothoracic anesthesiology. In 2011, he became the Thomas M. Dove Endowed Professor of Anesthesiology, and in 2013, he finally became the Robert L. Katz Professor and Chairman of Anesthesiology at UCLA. And just recently, in 2018, he was the newly appointed Chair of Anesthesiology and Director of Perioperative Services at the University of Pittsburgh. Dr. Mahajan is an extremely successful entrepreneur. He is a founder and Chief Technology Officer of 3 startups in the medical technology field. He's an extremely successful physician scientist. He has over 150 peer-reviewed publications. He's on several NIH study sections. He holds several NIH grants as PI, co-PI, or mentor. He holds 7 US patents. And he's editor or editorial board member of 4 prominent anesthesiology journals. Dr. Mahajan is the recipient of several Teacher of the Year awards, and his national and international recognition is well reflected by many visiting professorships at places such as Duke, Harvard, Yale, Penn, WashU, or Melbourne, just to name a few. So we're very excited and honored to have him here today. Thank you, Aman.
I want to thank everyone. We can't hear you.
Is that better?
Thank you.
Perfect. None of these disclosures have any conflict with the lecture. And I'll dive right into a report that was published in Nature about 115 years ago. And I'll, for convenience, your convenience, I'll just read it, a little excerpt. This occurred with the advent of chloroform anesthesia, and while it was highly successful and led to remarkable improvements in surgical care, but there were also a lot of deaths. And of course, this is an editorial published in Nature, and the excerpt here says, death from cardiac syncope has acted as an anesthetic to the conscience of the ignorant and careless anesthetist. So 2 points over here. One, arrhythmias and certain cardiac death under anesthesia has been a part and parcel of clinical practice for, again, as you can see, more than 100 years. The second part, which is coming full circle now, and I'll talk about it later, is that even 100 years ago, everything that went wrong was blamed on anesthesia. So it was only in 1911 by Levy and Lewis, it was discovered that these deaths that were occurring, and this occurred in part because in 1905, Einthoven invented the ECG, recorded the machine, and they found that all these patients were actually dying because of ventricular tachycardias and ventricular fibrillation under anesthesia. So as you can imagine, there are key reasons why we want to know about how cardiac arrhythmias are created. Firstly, and as most of you know, anesthetics, adjunctive meds, inotropes, vasoactive drugs, these are all drugs that we use in our practice, be that in operating rooms or ICUs or perioperative medicine. They can and do initiate cardiac arrhythmias. Moreover, physiological changes that occur, and they are part and parcel of our clinical practice, such as ischemia, hypoxia, electrolyte abnormalities, they occur all the time, especially during complex surgeries as well as in the ICU. In fact, some arrhythmias like postoperative atrial fibrillation is the single biggest cause of complications and morbidity that occurs after most thoracic and cardiac surgery, and is the biggest reason for prolonged length of stay for these patients. It's important to know these mechanisms because it'll allow you to have more precise antiarrhythmic drug therapy, as well as understand how some core practices in anesthesiology that you have, which is neural blockade or autonomic blockade and modulation, can actually be therapeutic in terms of expanding the scope of your clinical practice. But when I said we come full circle, there is also now a clinical practice that occurs in the electrophysiology catheterization labs where you're actually required to preserve the arrhythmogenicity. So when I say that now as an anesthesiologist, you're required in certain settings to reduce arrhythmias or mitigate arrhythmias, on the others, you actually have to make sure that they're preserved for therapeutic purposes. So understanding the mechanism actually helps you manage both the ends of the spectrum. Arrhythmias are fairly common, and there are several reports. Some arrhythmias are clinically insignificant, and some fairly have an impact. So how is a rhythm created? And some of this thing would be a broad overview for you, but nonetheless it's worthwhile going through this exercise to build on those concepts that you have. So a rhythm really is, as most of us you monitor for patients is in an ECG or a rhythm strip. Now, how that's created, though, is a summation of electrical events or electrograms that occur at local sites. So what you're seeing on our 12-lead ECG is the summation of electrical recordings that are occurring at different sites in the heart. And so think in terms of you have multiple different lens views, and all those lens views get summated and are represented as an ECG. Now, of course, that means while ECG is non-invasive, it's readily available, is inexpensive, it's also pretty inaccurate. In order to be accurate, you'd have to take those patients to a cath lab to truly understand where the abnormality of the electrical rhythms are coming from. So as you can see, different parts of the heart actually have different electrograms, if you will. And that's just because they have different electrical properties. So the cardiac the action potential, which really underlies the basic fundamental understanding and creation and how an arrhythmia is created. I just want to go over that profile. It's really a change in voltage that's occurring in a cardiac myocyte over a period of time. So it's a dV/dt for how a cell, an excitable cell, is changing its electrical potential. So this is in a ventricular myocyte. Initially, there's an opening of a sodium channel. As you can see, sodium ions come in, and that creates a rapid upstroke of an action potential, and that's the depolarization. That's when the myocyte electrical activity is initiated, and also is the initiation of the contraction phase, or trigger to the contraction phase. And then there is a brief repolarization that's called a phase 1, and that's due to a specific potassium channels called ITO channels. Details, again, not very they're important, but not necessarily for this purpose. Just recognize that there is a phase 1, and then there is a prolonged phase. It's a plateau potential. This largely occurs because of calcium channels coming in. And this is what leads to the excitation contraction coupling. So while there is a depolarization ongoing, the cardiac myocyte is also contracting, so that's called the excitation contraction coupling. Meanwhile, the potassium channels are also now starting to leak out to initiate the repolarization phase of the cardiac myocardium. And that's a phase 3 of the action potential. And then finally, the cardiac action potential comes, and the myocyte comes back to a resting membrane, and that becomes your phase 4. Now, this is typically how an excitable, but not a self-generating electrical action potential in a ventricular myocyte looks like. As compared to this, the pacemaker cells, and those pacemaker cells occur in the sinoatrial node, AV node, Purkinje systems. They actually are slightly different profile of the action potential. They do have a self-generating rhythm, so they have certain ion channels that don't exist in the ventricular myocyte. And essentially, and those are phase 4, which has a rapid active upstroke that occurs in these pacemaker cells. So if you think in terms of wave propagation, so cardiac electrical action potential is really a wave that's getting propagated in an excitable medium. It's just like you throw a pebble in water being an excitable medium, and you'll see the ripples actually move forward. So it's no different than what occurs in the myocardium, albeit a bit more complex. So you can think in terms of, as you think in terms of action potential as being a wave has a wavefront, and that's the upstroke, and a waveback, which is a repolarization. So depolarization and a repolarization phase. And the entire action potential is sculpted by these different ion channels that open and close at different times in the action potential time period. So as a wave propagates across the entire myocardium, you will see these series, a train of these single action potentials leading to a train of waves. So consider this thing as a myocardial tissue, and there's a wavefront, and then there's wave back. So as electrical wave goes across the myocardium, it will have these series of action potential that will sequentially depolarize and then repolarize. And that's a normal phenomenon that occurs 60 to 80 beats a minute, and for as long as your heart is beating or as long as you're alive. So then, what will cause the wave to change, right? So again, as I mentioned before, electrical waves have the same properties of a wave in an excitable medium. A wave is characterized by a wavelength, and a wavelength is your action potential, is a duration. That's your action potential duration multiplied by your conduction velocity. So, as you can very well imagine, to change the wave, right? So, for a wave to not propagate or propagate in an abnormal manner, you'd either have to change either the action potential duration or its conduction velocity. So this will become more relevant as we talk more about the applied physiology on these principles. Now these core properties of an action potential, which emanates from the ionic channel behaviors, really is what's utilized in creation of the antiarrhythmic drugs. So for instance, the class 1 antiarrhythmic drugs, those are the sodium channel blockers, they will work on blocking the sodium channel, thus they prevent the upstroke of the action potential, or this is what actually contributes most to the conduction velocity. And class 1 antiarrhythmics also have a dual effect on the phase 3 action potential. And then you have class 2, that are the beta blockers, and they affect both phase 2 as well as the pacemaker potentials in the pacemaker cells. Class 3, which are commonly used drugs for reentrant arrhythmias, those are the potassium channel blockers and primarily work on the phase 3. And then class 4 are calcium channel blockers, which are responsible for working in the plateau phase, and they decrease both. Thus, you can imagine that they can reduce contractility as well as they change the morphology of the action potential. And the classification really is called the Vaughan-Williams classification. What is important here to recognize is that while these antiarrhythmics have some specific properties for acting on certain phases of action potential, they're not clean drugs. They actually have adjunctive properties in modifying and modulating other parts of the action potential. So thus you can, while they treat one arrhythmia, they actually have a potential to create, in toxic doses or in aberrancies, some other arrhythmias as well. All right, bear with me. We're just getting started, right? So I know you feel, what do we come to? This is not an action potential lecture that we want to, I promise this is all that I wanted to talk about action potential. So when you talk about arrhythmias, most of us are used to classifying arrhythmias based on morphology. And that's helpful, but it's not really helpful in terms of understanding what the mechanisms are. And you can diagnose this and perhaps glean on knowledge that you've acquired on how to treat them to address the underlying pathology. The other way to think in terms of tachyarrhythmias especially is the ACLS classification. Now this is a pretty simplistic way of approaching this, and it's largely there to address immediate hemodynamic concerns or collapse for patients who are having severe arrhythmias. And all of you are familiar with this paradigm of understanding how to go down an ACLS algorithm in order to address the arrhythmia. What I would hope that you glean from this talk is thinking more in terms of the mechanisms, because the mechanisms actually allow you, as I alluded before, is to better understand how the arrhythmia that you are dealing with in your clinical practice, what were the basic physiologic or chemical or biochemical conditions that led to it. And I can tell you that will actually help you not just diagnose it, the clinical diagnosis of that, but also be able to help you approach it in the best manner in terms of its clinical treatment. So, and this is where we want to spend some time in detail going over each of these mechanisms. So this is really how also a lot of the cardiac electrophysiologists, perhaps not the cardiologists, but cardiac electrophysiologists think of classifying arrhythmias based off underlying mechanisms. So we'll go through that in a bit more detail here. So think in terms of disorders of impulse generation or disorders of impulse conduction. The disorders of impulse generation could be either as a result of automaticity, the principles of automaticity, or triggered activity. And the disorders of impulse conductions are really reentry. So for most of us to know, and many of you are aware of this, 80% of all tachyarrhythmias are really reentry. So even the arrhythmias that are initiated as a result of impulse generation, for them to sustain and propagate, they actually have to have some reentry at some point. Now, triggered activity, which again we'll go into a little more detail, is of two types. It's either delayed after depolarizations or early after depolarizations. And reentry can be either macro reentry over a large area of the cardiac muscle or micro reentry, as you will see. So let's just go over the first one, and it's a pretty important one, especially for anesthesiologists, because this is where we can actually become a lot more, expand our role as a therapeutic specialty. So as you can imagine, cardiac automaticity is the intrinsic property of the heart or the cardiac cells to generate its own rhythm, and largely it's a normal property, but it can become abnormal, and there are certain conditions for that. What you saw before, and it's up on the upper waveform, those are the cardiac pacemaker or nodal cells, and the action potential generation is dependent on calcium influx. These are sodium independent cells, and that becomes a little more important very shortly, as compared to the His-Purkinje system or ventricular myocytes that have a slightly different action potential profile, and they are not self-generating. They do not have, in normal conditions, they do not have automaticity. They're excitable, but not automatic, as compared to the nodal cells. So when you have abnormal automaticity, you essentially have a much steeper upstroke in these cells, and if these could be either a increased automaticity of pacemaker cells, or under certain pathological conditions such as ischemia, the normal ventricular myocytes can actually start developing an increased automaticity. And this is demonstrated right here. This is a myocardium, normal myocardium, or that becomes ischemic. As you can see, a normal ventricular myocardial cells has a resting membrane potential of -90. Now, what happens during ischemia or ongoing ischemia? The first thing that happens in myocardial ischemia is your membrane voltage actually starts becoming less negative. So over a period of very short 5 or 7 minutes, your membrane potential goes from -90 to -55. So what does that imply? What that implies is that normal myocardium, which was not automatic, which was not a pacemaker, did not have pacemaker cells, that membrane potential gets to be very closer to where sodium channels can open. So normal myocardium that becomes ischemic can actually become excitable and become self-generating in its own right. So when we start seeing PVCs occur, premature ventricular tachycardia complexes and tachycardias emanating from that, though during ischemia, that's what's happening in here. So a classic example would be during AAA or some major vascular or abdominal case, in a patient that has heart failure or ischemic heart disease, you start noticing new PVCs and signs suggestive of myocardial ischemia. You essentially are in that region of myocardium, the membrane potentials are becoming more positive or less negative, and they are being brought closer to a threshold so that those cells are becoming now functioning as pacemaker cells and creating abnormal rhythms. Thus, you start giving lidocaine, which is your class 1 blocking drug or a sodium channel blocking drug to reduce that. So the clinical arrhythmias, one important feature to recognize is that these arrhythmias, secondary to increased automaticity, they're also very much influenced by beta stimulation, by autonomics. So increased beta stimulation will enhance automaticity, and decreased vagal stimulation will decrease it. In fact, one of the most exciting areas of research right now is really in how to enhance vagus or vagal effects to reduce myocardial ischemia. And there are several trials that are showing in preclinical studies that if you increase vagal activity, the amount of infarct actually becomes less. And what I'll show you tomorrow in our research seminar is that you can achieve the same effect by reducing central sympathetics or spinal cord stimulation. You will actually decrease the amount of myocardial infarct. So the clinical arrhythmias that you see in your practice from this underlying mechanisms are listed over here. So how do you treat it? So I told you what are the mechanisms underlying that. It really is the slope of the phase 0 of the action potential, which is, as we looked at the antiarrhythmic 1 classification, can be really be mitigated by the beta blockers here. So this cell that is becoming potentially having an increased automaticity with an increase in slope, what you do is when you give beta blockers, you essentially are decreasing the slope here of the action potential. Right here, this used to be the threshold potential before the drug was given, and now you've actually pushed the threshold potential up for these cells. And at the same time, beta blockers will enhance the action potential duration as well. So decreasing the rate of phase 4, so the number of beats being slow, the slope of phase 0, as well as increasing the length of the action potential. Remember what I said? Action potentials really are electrical waves, and they depend upon action potential duration and the conduction velocity. So if you change either of the features of either of those two components, you can mitigate a lot of arrhythmias. The second underlying mechanisms from disease propagation disease is triggered activity. So triggered activity is, as the name suggests, it's triggered following an action potential. It's not a self-generating rhythm. It requires prior electrical activity to initiate. Two types, DADs and EADs. As demonstrated here, delayed action potentials occur after the completion of a prior action potential. So you see it's an oscillation. All that it is, it's an oscillation of membrane potential that occurs after the prior action potential is complete. Now, if this oscillation reaches a certain threshold, it can generate its own action potential or series of action potentials, which would be the arrhythmia or tachyarrhythmia that starts after triggered activity. And we'll talk about what creates triggered activity. Now, EADs, on the other hand, they actually occur when the oscillation of membrane potential occurs before the action potential finishes, right? So this is an oscillation during an action potential right here, and if it is big enough in terms of voltage, it'll create an arrhythmia unto itself that triggers. So let's look at DADs. And here, there was a normal rhythm, but there was an after depolarization. Most DADs actually are innocuous. They occur all the time. If you look carefully on the mapping that's done in the electrophysiology labs, you'll actually see these being mapped all the time on the electrical rhythms of the EGMs with different catheters. And they become manifest only when they actually or significant voltage change and are occurring repeatedly. So this is, again, an example. And they largely are due to calcium, an excess of calcium influx that occurs. So they're calcium-dependent DADs that occurs during the repolarization phase of the cardiac cycle. Now, cardiac myocytes are extremely effective, have an extremely effective machinery to manage these ion channels, right? So you can imagine the heart has to beat 60 times in a minute or 80 times in a minute so it's been highly engineered to manage all of these things in normal. But clearly, myocardial ischemia, heart failure, and so many other conditions, genetic changes, can actually lead to a perturbation in this otherwise highly efficient machine. And clearly, in the perioperative period, we know that we deal with calcium and other electrolyte imbalances all the time. So you can certainly see these complex mechanisms, and again, not going too much into detail, but there are several mechanisms that actually do lead to a perhaps decrease in removal of calcium that occurs during diastolic phase or repolarization phases. And, as pointed out before, these conditions, these are ischemia, acidosis, ditch toxicity, less so seen now, but still. And we did a survey across the 2 continents, and ditch is still fairly commonly being used. Increased catecholamines, which we see in our clinical practice a lot, and that's one of the big reasons for seeing DADs in clinical settings. And some of these are genetic changes, such as modifications of ryanodine receptors. So the clinical arrhythmias that are seen as a result of DADs are dystoxic, induced tachys, MI. When you have myocardial ischemia, again, you can have increase in calcium overload that occurs in the cells. In the setting of excess catecholamines, and that's pretty common, especially in women, young women that are coming in for cath ablations, you can have what's called the RVOT VTs, and these are arrhythmogenic foci that get triggered fairly easily by excess sympathetics that occur in these patients. In men, it's more on the left ventricular side, so RVOT and LVOT VTs. These are the catecholaminergic polymorphic ventricular tachycardias. And you'll see these terms being now, when you go back to cath lab, you'll see these terms being used a lot by your cardiac electrophysiology colleagues. So the other part of the triggered activity is the EADs and the early after depolarizations. They occur during the repolarization phase, so before the action potential finishes, oscillation of a membrane, it reaches a certain threshold and it creates a self-generating rhythm, as you can see here. And the key part of this is that it requires the action potential to be prolonged. And again, as you've experienced, action potentials can get prolonged for many different reasons: drug-induced, antibiotics, antihistaminics. Those are all, they have FDA, some of them have FDA black box labels as well. So as you can see over here, there is a EAD that occurs and that degenerates into a ventricular tachycardia. A common arrhythmia that falls into this genre is really your torsade that occurs. And that occurs, as you know, is in setting of prolonged QT interval. So a prolonged action potential manifests on an ECG as a prolonged QT. But now that you've seen the underlying different ionic mechanism, there are many different reasons to actually have a prolonged QT. Electrolyte abnormalities, they're fairly common, and they actually have an impact on the action potential duration, thus can lead to EAD-induced arrhythmias, and these are hypokalemia, hypomagnesemia, and bradycardia. So these are some things to be aware of. I talked about the drugs, and then certainly antiarrhythmics. I told you antiarrhythmics are fairly dirty drugs. They're not clean. The class 1 drugs and class 3, they actually prolong the action potential. That's how they are antiarrhythmics. But at the same time, in these patients that have an underlying predispositions, they have a high prolonged QT, they actually can create EADs and lead to secondary arrhythmias. So that brings us to reentry, which is 80% of our tachyarrhythmias, something also that we deal not just in our clinical practice, but also clinical practice in the operating rooms, but also in the cath labs where these patients are coming in for either AFib ablations or VT ablations. So as the name suggests, it's reentry is reactivation of the myocardial tissue that's already been activated by the same impulse. So this is what a normal myocardial activation looks like. As you can imagine, in the heart, there are many anatomical obstructions that occur. There are fibrous zones, there are papillary muscles. It's a three-dimensional complex structure, right? So, but electrical waves, going back to the schematic that I showed, it's a wave of propagation that goes from one part of the heart, and sinus node in most people, normal people, and then essentially depolarizes different zones of the heart. It's one impulse that essentially will depolarize, activate every part of the heart. Now, during that process, it reaches some anatomical obstructions, right? So consider this to be an obstruction. That's okay. A part of the impulse will go take this route, and the other impulse will go take the other route. Because these parts of the myocardium are all at the same electrical potential, these waves eventually will collide and extinguish themselves. And that happens with every beat. Unlike in patients where there is delayed conduction, and delayed conductions can occur either as a result of electrolyte abnormalities, ionic channel problems, they could occur as a result of myocardial ischemia. So you have a zone of delayed conduction over here. This is classically how a myocardial scar looks like. You have normal myocardium, you have on either side. The scars are not complete scars, and what we are finding is most scars, even well-developed scars, have islands of normal myocardium. Or normal, they have islands of excitable myocardium in them. So many of the PVCs that trigger these arrhythmias are either occurring from the border zones, which have delayed conduction, or these areas of slow conduction that occur within the scar. Now that makes sense because when the cardiac electrophysiologists are in the cath lab, what they are trying to do is to ablate these. When they're saying they're ablating these scars or regions of delayed potential, they're trying to essentially create fibrosis or create an insulator in these areas of slow conduction. So in this, a normal electrical wave will essentially excite all the normal tissue, but it finds the region, the ischemic regions, for instance, to be non-conducting, and essentially this area will get depolarized at a later stage, and not in the same excitable wavefront. But when this area now essentially becomes re-excitable, this delayed wave that was, because as a result of delayed conduction comes back, it now essentially can create a re-entry pathway. So the same wave, as a result of delayed conduction in one region, if it finds a path to excite a normal tissue, will create circle re-entry. And that's the re-entry that is responsible for 80% of the arrhythmias. So arrhythmias can get started as abnormal automaticity or triggered activity, but to sustain them does require re-entry. Re-entry occurs across large regions of the heart, and you're familiar with many of these arrhythmias. These are macro re-entry. One type of macro re-entry arrhythmia is a WPW that you're familiar with, and that occurs through this bundle of Kent. By the way, 70% of people in this room actually have a bundle of Kent. We have a lot of accessory conduction pathways that exist anatomically in many of us between the atria and ventricle. It's just that they're not clinically active for most of us, but they can become in the right settings or the wrong settings for the unfortunate patients, right? So macro re-entries occur across large regions of the heart. Micro re-entries are occurring in small regions of the heart. An example of the micro reentry, or examples of micro reentry, are atrial fibrillations, and you'll see some examples of that occur in small regions in the left atrium, and ventricular tachycardias that can also be micro reentry arrhythmias, especially around regions of myocardial ischemia. And these are the examples of the clinical reentrant arrhythmias, SA nodal reentry, SVTs that are associated with accessory pathways like WPW, AV nodal reentrant. So you can have AV node that itself serves as a reentry pathway over here, and it can essentially serve as because the reason is that AV node actually has the slowest conduction in anywhere in the heart. So in some conditions, it can serve to create a macro reentry pathway or a micro reentry pathway within itself. So that brings us to cardiac fibrillation. The underlying mechanism for atrial fibrillation or ventricular fibrillation is actually from an electrophysiological standpoint, is actually the same. The underlying physiological or pathophysiological mechanisms can be different. Atrial fibrillation is more of a systemic disease. Myocardial ventricular tachycardias are more of local disease, cardiac disease. But as you can see, they have a pretty high significant mortality and morbidity. VF, or sudden cardiac death, is from VF is the largest cause of death in the country, more so than all cancers combined. And atrial fibrillation, of course, is one of the biggest scourges for populations at large, and responsible for the biggest healthcare cost burden that exists in aging population in the country and the rest of the world. So electrophysiologically, what's happening with these waves? Right? So how is this rhythm, this ominous rhythm, created? When you see that you have a sinus rhythm, and every VF that occurs actually has a VT that precedes it. Now, it might be a 2-beat ventricular PVC, but the transition is not from sinus to VF. There always is a beat or 2 or 3 of ventricular tachycardias. Okay? So that's an electrical phenomenon that you see on the ECG, and what's happening over here, using our paradigm for electric conduction, these are depolarization waves, one after the other. The action potentials are going through the myocardial tissue. They see a region of obstruction, and this could be myocardial ischemia, scar, electrolyte abnormality, any of those conditions. And what's happening here is that if this region is large enough, electrical waves, again, going back to properties of waves in an excitable medium, this wave has enough of an energy to propagate and depolarize the entire myocardium. If it reaches an obstruction, these waves become smaller. Small waves that they don't have the energy to actually excite the entire myocardium. They don't propagate linearly. What happens, they start curling around the edges. And they start becoming, and as the energy of these waves becomes smaller and less, they become more and more circular or spiral waves. So that's really what happens. Again, no different than the phenomena that you see when you are, relaxing and throwing stones in a pond. And this is an example. This is, again, we've done all this mapping in human myocardium, animal myocardium, in silico, and this is what you're seeing as an electrical wave over here is really a characterization of how the electrical action potential and voltage is changing across the myocardium. So this is the ventricular tachycardia. It's a spiral wave, as you saw, and this is represented by these first few beats. And as the waves start degenerating, becoming smaller and smaller, that's a VF onset. These spiral waves start breaking off at the tips and the edges and create these small wavelets. And these wavelets now become self-generating. Each wavelet, because it doesn't have the energy to propagate, it becomes even smaller wavelength. So essentially becomes a self-sustaining. Unless you actually depolarize massively this myocardium by electrical shock, these waves will continue to keep breaking down into wavelets, which is what your VF is. And this is an simulated electrical myocardium. A normal electrical beat goes through. Red is depolarization, followed by a wave back. A PVC occurs and becomes a spiral wave. And as you'll see over a period of time, the tip of these waves can propagate linearly. The PVC occurred in the region of slow myocardium, which is myocardial ischemia, and essentially keeps degenerating into VF. So how do you treat this? So the class 3 drugs are the drugs that are used for treating reentry. So realize the underlying mechanism is that you have delayed conduction here. So you have to either completely stop conduction in that region, and that could be done by either you ablate that region or you choose a drug that can completely block that reentry over here. And the drugs are class 4 drugs that essentially are working in this region of delayed. This is where subendocardial myocardial ischemia is occurring, and it blocks the conduction in that region. So a reentry circuit is blocked. So you're not actually treating or making the myocardium better. What you're doing is you're making sure that no electrical wave can go through that region. And the way it manifests on the ECG is it prolongs your QT, but what it is doing is it's essentially prolonging your action potential duration. Again, I go back to the construct that either you change action potential duration or you change your conduction velocity to treat arrhythmias. You're familiar with these drugs, commonly used in your practice, and these are all class 3 drugs, either are going to be used for atrial fibrillation or for ventricular fibrillation. Now it makes sense why you're using the same drug, because the underlying mechanism is reentry. A quick note about atrial fibrillation. The mechanisms are, it's a multi-systemic disease, but the regions where atrial fibrillation occurs from, they're actually fairly well defined. Vast majority are in the left atrium, 10% of AFib occurs in the right atrium, and 90% is on the left atrium. And the left atrium, these are the key zones, regions that have been identified that create these ectopic or rapid ectopic activity, vagal ganglia, ligament of Marshall, back wall of the left atrium, and certainly vast majority of the ectopic activity or atrial fibrillation arises in the pulmonary veins. Now, unlike ventricular tachycardias that can create these meandering waves and self-generating wavelets, because these are focal, fast, rapid depolarization, essentially it's the same phenomenon of spiral waves, but it's coming from a single focus, and the waves don't propagate over a period of large myocardium. I think AF is something that we will continue to see increase in prevalence with aging population, and especially as aging population comes in for surgery or be in our ICUs. I previously mentioned that it is the single biggest reason for cardiac and thoracic patients' morbidity after surgery, and the costs are substantial, not just from length of stay, but also from the treatments, therapies that we implement for these patients. So as you can see here, multifactorial. The problem with atrial fibrillation is once atrial fibrillation starts, from whatever the mechanisms, and there are several mechanisms and pathways that can create AF. So you can have atrial structural abnormalities, you can have essentially electrical abnormalities, or autonomic influence, genetic variations. They all intersect and interact with each other in this complex network. And so one event, one perturbation can trigger the others, and once AF starts, it essentially, AF begets AF. And the treatment has to be either chemical or pharmacological, or has to be an electrical ablation. So we had set up, as part of the SCA and EACTA we set up a AF task force, realizing the importance of that and perhaps importance of anesthesiologists, specifically cardiac anesthesiologists and intensivists, to see could we actually understand why we are not able to overcome the scourge of disease, especially for post-surgical patients. So we set up this task force a couple of years ago, understanding that even though there are some guidelines by American Heart Association, ACC, ATS, where is the gap? We do have class 1 recommendations for certain drugs in certain conditions and class 2 for certain other. Why is it that the incidence of atrial fibrillation is still remains persistently high? In some patient groups, it's about 50% after surgery. So we did a survey, and the task force included not just the anesthesiologists, it included cardiac electrophysiologists and included surgeons as well, who were more interested in cardiac arrhythmias as a specialty. And what was very interesting is that while most people were aware, most physicians were aware that these recommendations exist, and they exist in public domain as guidelines by these respective scientific societies, what we found is that the implementation of that was fairly weak. So as you can see, these are patients, the SCA patients as well as EACTA patients. The use of prophylaxis was particularly poorly implemented in spite of clinical evidence across both in US as well as in Europe. There was more concordance with implementation of clinical guidelines as a treatment, but not as a prophylaxis. So for instance, beta blockers use was only 60% or 50% for US and European physicians, cardiologists, and electrophysiologists. So we did go in detail about what were the reasons, even though this is a fairly knowledgeable group that's committed to improving clinical outcomes for those specific patients and generally more familiar with the specific scientific guidelines. And some of the barriers that came in as poorly structured clinical guidelines and protocols across different organizations, a sense of lack of understanding of mechanisms of cardiac arrhythmias, a fundamental fear of using cardiac antiarrhythmic drugs, that they might trigger some other adverse manifestation, and that prevented use of certain drugs, and many other reasons which came forth. A significant reason was a poorly understood, and even the guidelines from AHA and ACC, while they individually say the role of let's say beta blockers or amiodarone as being class 1 or class 2 evidence, it is unclear how they describe the patient who's at risk. Most of these guidelines are for patients that are at risk without describing how do you actually create the risk model for each of these patients. And so we said, all right, maybe perhaps what we could do as a contribution is to create a more simplistic way of addressing these. So we created a schema identifying the risk being from the risk factors being listed over here as being age, history of AF, renal failure, mitral valve surgery, heart failure, COPD, and creating more of a clear visual table with green and yellow and orange indicating the level of evidence that exists for these patients. So I think, and the hope, of course, is now we're implementing this and we'll track, do we or the centers that actually use this approach can have a better treatment profile or use of evidence-based guidelines for treating postoperative AFib. Let me, I know we are getting pretty close to end of time. I will stop right here, and if there are any questions I can take now or certainly later on. Thank you very much. There you go. Thank you very much. Thank you.